access to care and health equity, and we'll hear from Lois Uttley, co-founder of Community Voices for Health System Accountability, a statewide alliance that is raising consumer voices as health systems propose mergers, acquisitions, new construction, downsizing, and closing of hospitals. Lois also teaches in the Master's Health Advocacy Program at Sarah Lawrence College. Lois has dedicated 25 years to protecting patients' rights and their access to care when health systems are consolidating, and we're so grateful Lois is here today. Lois?
Yes, thank you so much. I'm hoping you can hear me. Yes?
Yeah.
Okay, good. So thank you so much for the opportunity to say a few words about how hospital consolidation is affecting communities' access to care and health equity. I want to try to give you the view from the front lines at the community level. Next slide. So hospital consolidation is really changing the healthcare landscape for patients. Their community hospitals are joining large health systems that then shift decision-making to out-of-town executives. And often these executives look to eliminate what they view as duplicative services that can be found at other hospitals in the system. People are also seeing their community hospitals closing or downsizing. Hospitals are shutting maternity care, and they're closing or reducing the hours at hospital ERs. Next slide, please. As you've heard Zach and Raul explain, increasing numbers of hospitals are joining health systems. The American Hospital Association, and this is their graphic, thank you, reports that there are now 407 health systems in the US, and that more than 2/3 of all hospitals belong to one of these systems. You know, being part of a large health system can seem very attractive to hospital boards and CEOs, particularly those struggling with financial issues. But often these mergers come with a big catch for the people who depend on the hospital for their medical care. Next slide, please. So I've worked with dozens of communities across the US where health systems have made big promises about the benefits of mergers or acquisitions. And here are three popular examples. They may say, the merger will stabilize your hospital financially and ensure it's still here for you in the future. They may say, the merger will improve the quality of care at your hospital. And you've just heard from Zach Cooper that that often is not a promise that's fulfilled. And third, your hospital will have access to capital needed to carry out renovations of aging buildings. Next slide, please. But once the merger goes through, those promises often are broken. And the post-merger effect can be like some of the examples I have here, where communities are then told, oh, we're closing maternity care, but you can just go to our other system hospital 25 miles away. Or the community may be told, we won't be allowing contraception, tubal ligations, abortion, or other reproductive health services that violate our system's religious directives. Or often a private equity firm that's acquired a hospital may say, to achieve optimum efficiency and effectiveness, we need to cut the hospital staff by 25%. And sometimes the news is very dire. Unfortunately, we must close your hospital entirely. Now, sometimes it can take several years for the other shoe to drop in what I call the post-merger effect. For example, here in New York City, where I'm based, the Mount Sinai Health System took over Beth Israel Medical Center through a 2013 merger with the Continuum Health System. But 6 years later, in 2019, Mount Sinai tried to close Beth Israel. That plan fell apart when the pandemic hit and all available hospital capacity was needed. But now, Mount Sinai is back, planning to close Beth Israel and leave a large swath of downtown Manhattan with diminished hospital capacity. Thank you. Next slide. So who is harmed by hospital consolidation? As Zach Cooper has explained beautifully, hospital consolidation has often been shown to increase the price of healthcare, and that ends up increasing premiums and harming people with high deductibles, as well as people who are uninsured, and they can end up in medical debt as a result. But access to care and health equity are also harmed. People in rural areas can be left without ready access to medical care. People in low-income urban neighborhoods of color often feel abandoned by health systems that are closing their hospitals and instead moving into suburban areas where people have commercial health insurance. Women and other people capable of pregnancy can be forced to travel long distances for maternity care or suffer the loss of reproductive health services. These changes can pose real problems for people with disabilities and elderly people who cannot easily navigate changing health delivery systems, and also for LGBTQ+ people who often struggle to find healthcare providers they trust and then can lose them in these hospital changes. Next slide, please. So now I want to talk about an approach that one state, New York, where I'm based, has taken to try to introduce a health equity consideration into state review of proposed hospital consolidation. You know, when COVID-19 hit the state really hard in early 2020, I and some other health advocates, we raised concerns about how decades of hospital consolidation had left some communities without enough hospital beds. So former State Assembly Health Committee Chair Dick Gottfried and State Senate Health Committee Chair Gustavo Rivera sponsored a bill that was intended to introduce health equity into state review of hospital transactions through our state's Certificate of Need program. The measure was signed into law in December 2021 by Governor Kathy Hochul, and it then underwent an 18-month rulemaking period that engaged both health advocates and health facility representatives. And the law is being administered now by the State Department of Health's new Office of Health Equity and Human Rights. Now, let me just briefly tell you what the law requires. When a proposed health facility transaction would cause the elimination, reduction, or relocation of services, health facilities must hire an independent assessor to do an assessment of what's the likely impact of the change on medically underserved people. And you can see on the slide that medically underserved includes low income, uninsured, women, LGBTQ+ people, racial and ethnic minorities, immigrants, people with disabilities, rural residents, older adults. The assessor is supposed to conduct meaningful engagement of these folks and come up with the likely impact, as well as a proposed mitigation plan to address any negative impacts. The assessor, by the way, is supposed to be independent, have expertise in health equity, and no conflicts of interest, like an interest in approval of the transaction in question. Next slide, please. So the first test of this new law has been the proposed closing of the only maternity service in upstate Rensselaer County. That county used to have 3 hospitals with maternity services, but 2 of them were closed through successive rounds of hospital mergers. The surviving facility, called Samaritan Hospital, joined the St. Peter's Health Partners system, which is part of the National Trinity Catholic Health System. And because Trinity doesn't allow certain reproductive services, a separately incorporated hospital within a hospital was created to allow access to postpartum tubal ligations. That creative solution, however, fell apart in 2020 when Burdett was reabsorbed into Samaritan Hospital due to financial and staffing issues. So, okay, no reproductive services, but at least maternity care was still there. But then last spring, St. Peter's suddenly announced that it was closing the Burdett Birth Center entirely because it has been losing money. And the system said the pregnant patients could travel across the Hudson River to the system's hub hospital in Albany County. Next slide, please. There was a really strong outcry from the community, which would be losing its only maternity service. And by the way, that Burdett Center also serves people in several adjacent rural counties. Even the local Catholic bishop spoke out in opposition. Next slide, please. So how did the health equity law come into play? Well, St. Peter's filed its certificate of need to close the birth center 2 days before the new law went into effect. After considerable public criticism, St. Peter's reluctantly agreed to go ahead and commission a health equity assessment. They hired the Chartist Group, a national consulting firm that often advises hospitals and health systems, including Trinity Health, the parent system of St. Peter's. Next slide, please. A local coalition, the Save Burdett Birth Center Coalition, that includes midwives, doulas, and public health people, decided they would do their own health equity assessment following the model from the state. Frankly, they were mistrustful of what the study commissioned by St. Peter's would find. The coalition found that many people who have given birth at Burdett praised the midwife-led model of care and low rate of C-section deliveries. Black pregnant women, and you can see a quote from one of them on the slide here, said they feared the loss of Burdett, where they felt respected and listened to after many hurtful experiences with other health providers. And I should say that in Troy, where Burdett is located, many low-income people depend on having the birth center close by. Nearly a quarter of the people in Troy live in poverty, and 22% of the households have no cars, and thus no way of going to another birth center. So there are also many rural residents who depend on Burdett. Next slide, please. So the Chartist Group did the health equity assessment, and many of its findings actually echoed what the community group had found in terms of health inequities and some significant transportation problems. However, in the mitigation section, Chartist then just accepted St. Peter's claims that it could arrange transportation for pregnant people and that patients could go to St. Peter's and use midwives there, even though only 16% of the births there are currently attended by midwives. At a forum the other night, the CEO of St. Peter's credited the health equity assessment as being helpful in identifying health equity issues. And he and the system said they would delay the planned closure of Burdett and engage the community. It remains to be seen, however, how robust that engagement will be and whether there are any ways to really mitigate the negative impact of closing the birth center. Wanted to just note that meanwhile, the State Attorney General, Letitia James, has also stepped in. She has regulatory authority over nonprofit charities, including St. Peter's Health Partners. So she's been looking closely at this closure. I want to flag that some other states are also looking at health equity in addition to price effects of competition, including Oregon and Minnesota. And as both Zach and Raul have noted, President Biden has said that hospital mergers are leaving many areas without good options for convenient and affordable healthcare service. So I'm eagerly anticipating the release of the FTC's new merger review guidelines and hope there can be some way to incorporate health equity concerns there. I'll just finish by flagging a few resources you can consult for more details about what I've discussed today. Thank you.
Thank you, Lois. Thank you to all of